Everybody, good morning, good afternoon, good evening to anybody from all around the world, all of the PSC patients, their families, and everybody else that's here today with us. We're very happy to have all of you here with us and have physicians from around the world that are willing to help us discuss the theme of this year's Global PSC Day, which is the quality of life of patients with PSC. Mary from PSC Partners in Canada is here with us as well, and she's going to help me moderate today. And she'd like to introduce the different positions to you right now. Okay.
Good morning, good afternoon, good evening to all of our speakers who are joining us from multiple time zones. I would like to welcome our speakers. We have with us from, I'm trying to think geographically how I should do this. I'll just go down the list. We have Professor Dr. Doug Thorburn, who is a professor of hepatology at University College London. Welcome. We have Dr. Kate Lynch joining us, who's head of inflammatory bowel disease services at Royal Adelaide Hospital from Australia. Welcome. And Professor Dr. Thomas van Wollinghem, specialist in gastroenterology and hepatology, Antwerp University Hospital, Belgium. Welcome. Thank you so much for joining us today.
Okay.
Thanks.
We're going to start. Some of the questions might be very difficult for people to answer, to ask them, but these questions were put together by all of the patients all around the world. Today, the first question I'd like to ask all of you is, what do you suggest a PSC patient suffering from chronic bile duct infections that destroy their quality of life?
I'm happy to take that first. So that one of the challenges of PSC is that the symptoms of bile duct infection, cholangitis, can be quite broad, from very obvious infection, which we would see in patients that have other causes of bile duct infections, to quite mild symptoms of discomfort, and maybe a mild fever, or maybe not even a fever. So we kind of recognize that bile duct infection is a common problem, and it's probably under-recognized by clinicians that are not used to caring for patients who've got PSC. So the approach, first of all, would be to try and treat early if the diagnosis is suspected, and then do some investigations with, and that would be antibiotics to treat, and then do some investigations, including bloods and possibly imaging with an ultrasound and then likely an MRI scan to look for evidence of some kind of complication of PSC that might be causing the infection, like a stricture or a narrowing in the bile duct. And then in light of what these investigations find, there might be justification to proceed to doing an intervention to deal with the problem, like an ERCP to deal with a narrowing in the bile duct. But in some instances, there's no clear obstruction in the bile duct. There's no clear intervention that can be undertaken to prevent the attacks. And then it becomes an issue of dealing with the infections as and when they arise. And then in those patients get very frequent and recurrent bouts of infection. In rare cases, patients will be put on cycling antibiotics, which would be maybe a month of one antibiotic, a month of another, and then potentially a month off antibiotics. In rare cases, this would be an indication for taking patients to liver transplantation, when infections are really difficult to control and it's having a real impact on quality of life. So there are things that can be done both in the acute episode, but also to prevent recurrence, and also to deal with those patients that are having very frequent recurrent episodes of infection. I don't know if others would wish to add to that.
Well, yes, I fully agree with Professor Thorburn. So Belgium is part of Eurotransplant. So we have a specific number of member state, 8 countries that share organs depending on the priority for liver transplantation. And we have a specific non-standard exception for patients with recurrent bile duct infections. And basically, when we really did all the steps that Professor Thornburn just explained, and we have a formal proof of recurrent infections, mostly shown by a bacteria in the blood culture. If that is the case, and we have that up to 6 times, then we can ask for extra points on the waiting list. So this is something that we really try to document as well as possible. Also, we invest a lot of time and work to document the type of bacteria that is involved, especially to determine cycling antibiotics because of the sensitivity of the bacteria that are involved. So mostly we are, and it may be a bit strange, but we are happy that if we find a bacteria, because then we know, okay, this is what we can give. We look at the antibiotic sensitivity of these bacteria, and then we focus our treatment on the sensitivity of these bacteria.
And maybe if I add at the other end, so at the start, before we get to these very crippling or, very recurrent infections, I think as hepatologists, we should make sure that patients understand what the symptoms and signs are of cholangitis, and know about acting on it quickly, and patients having their own prescription at home if they've had an episode of cholangitis before, so that they can go and start oral antibiotics as soon as possible to prevent it getting serious and needing to go into hospital, because these infections can go into the bloodstream, like Professor Van Walligem was saying, and then that's even worse on your quality of life, having to go to hospital. I know that PSC Support UK have patient information sheets and cards that you can carry that also have advice that you can give the emergency department doctor or a doctor who's not as familiar in ascending cholangitis to help people with PSC get prompt treatment, and doctors less familiar with the disease recognize the signs better. And the only other thing I would say is we're very careful as hepatologists not to do endoscopic therapy unless we really need to. So I definitely agree with Professor Thorburn that if there is a stricture and significant cholangitis, it may be that we need to go and do something to that and dilate that stricture. But we try and not do an ERCP until we really need to in someone with PSC, because the longer we can go without doing an ERCP, the longer we can go without potentially introducing any bacteria that could then be the cause of recurrent cholangitis. So I think they're just my things I'd add to, and I agree with everything that Professor Thorburn and Professor Van Walligem said.
Can I add a quick question to this? Something that gets debated online on the patient communities is patients, especially those who've have had bouts of cholangitis and have been hospitalized, really don't want to go to the hospital. So there's often chatter, oh, here we go again, I don't want to go. And people are giving each other advice. How long, everyone would prefer to manage this at home. If you don't have a prescription and are not able to get in touch with your doctor, once you have signs of a cholangitis infection, how long would you wait before, or how long would you advise they wait before going to a hospital?
Shall I come back? So I think if they've got typical symptoms, they shouldn't wait at all. So if they have fever and pain in their tummy and maybe become jaundiced, then they should act on that immediately. If the family are unwell and the person's got a bit of a fever and they've got a runny nose, and that you might wait 24 hours and see how things evolve. But I wouldn't hesitate in people that are developing classical symptoms. And as I said at the start, the symptoms are often not as they're written in a textbook in patients with PSC. And sometimes it's helpful if there's an easy means of engaging with the clinicians that you're involved in, a nurse or the doctor, seek their advice early on about what you ought to do in those circumstances, because there's a good chance, because it's a rare disease and lots of people are unfamiliar with it. If you present in the standard way to the emergency, to your GP or to the emergency room, that your symptoms won't be recognized, or the connection might not be made with an infection. So I think that's, coming back to Kate's point, a really useful alert card that PSC Support have produced to inform the patient, but also to involve the clinicians that are involved in the care as well.
Thank you.
I can add something on there as well. I think that the fact that many physicians that are young and things like this that don't really know what PSC is. I'm a PSC patient myself, and I remember one time many years ago at the emergency room, I heard the doctor saying to himself, "So what does she have?" You know, this is something that if it's not a physician that knows what PSC is about, you have to have a physician that really knows, that has treated more than 1 or 2 patients with PSC. And this is something that, you know, you as hepatologists, I'm sure you understand my opinion about that. I think that's something that's very important. But that gets us on to another question, that what do you suggest for PSC patients suffering from acute pruritus, and that really destroys their quality of life? That I can say personally, that I know what it's like when there are nights that are sleepless and that you can't sleep and you can't function the day after, and you can't function at all. And when people keep telling you to stop itching because they don't understand it, what do you suggest to help people that have pruritus that's really severe and they can't have any sort of a quality of life? They can't work, they can't go to school, they can't do anything that they need to do.
I might answer that one. So I think, I mean, I find a lot of my patients who have itch play it down when they talk with me, and they don't want to go on another medication or go on something else. Although when they do, it often can make a big difference. So I guess that's an individual decision, but I would make sure that you go through your different options with your specialist, because there's a pipeline of options that you can do. And if one thing doesn't work, then we do have further options available. And some things work for some people and some work for others. Often first line, just having a cooling shower and having some menthol, some aqueous cream with menthol in it. It's not enough long term, but sometimes just to get to sleep, it can be enough just to put it on to get to sleep. Antihistamines haven't been shown to work. Occasionally they can have a bit of a placebo effect, but it's always worth a try, because, but generally they're not proven in PSC. The first line used to be cholestyramine or Questran, which is a bile acid sequestrant, and it's thought to bind up the bile acids, which may be part of what's causing the pruritus, the itch. Although more recent guidelines have actually not suggested using this first line and going on straight away to a drug that works quite effectively in a lot of people called rifampicin. And rifampicin is an antibiotic which is not absorbed by the gut. It mainly stays in the gut, and it can work very, very well for itch. Sometimes the liver test can go off, which is a little bit disconcerting, but only in a very minority. And the other off-putting things is it can stain your secretions in your, like your sweat and your urine, a little bit orangey yellow, but it can be extremely effective, and the dose can be pushed up a little bit, start at 150 twice a day, then 300 twice a day. So after you've done that, there are other therapies, such as sertraline, a selective serotonin reuptake inhibitor, an antidepressant. And then just more recently, also, some countries are using something called fibrates, like bezafibrate or fenofibrate, which is actually being looked at in PSC as well as another biliary disease, PBC. And they were originally licensed for lowering cholesterol, but we now think that they also can be used in biliary disease and for itch. And so the final thing I'd say is that if you're really having debilitating itching, especially if you're in North America or Europe, then I would get online and look up or ask your specialist, but also look at whether there's any trials around your area for itch in PSC. And we might be talking about that soon, but there are some clinical trials coming out of newer agents which can be which may be quite effective for itch. So I just say, don't lose hope if you're debilitated by itch, because there's a long pipeline of therapies. We're starting to develop new ones and get better at it. And if all else fails, very, very occasionally, people can have a liver transplant for intractable itch. And if you have a liver transplant, the itch just goes away like that. Everything else takes a little while, a few days to get better, the jaundice, etc., but the itch just goes like that.
Well,
Cynthia?
I don't have a lot of to add. I think this is a very answer covering all the spectrum of possibilities. What I do focus most on in my patients is their night rest, and that's really, really important for them, because it can be so hard if you are debilitated by itch and you cannot sleep, and people sometimes get really depressed just because of the itch. So for me, that's really an alarm symptom if patients cannot sleep because of the itch, and then we really try to pull all the arsenal of the different medications that we have, and if it's not working, we've done some UVB therapy also, which had some good responses in patients. So as Dr. Lynch said, indeed, there's the whole spectrum of options, and do not be afraid to mention the severity of your itch, and discuss with your doctor and how severe it is, and how it impacts your life, because there's several things that we can do.
I'm maybe come in just add a couple of comments. One is that the evidence behind a lot of these treatments is not that strong, although everyone sees patients that benefit from each of them. So there is an element of trial and error to the approach that's taken. And I think exactly as Thomas said, I think if one is ineffective or isn't tolerated, it doesn't mean that the symptom can't be controlled. It just takes a little time to kind of get on top of things. The other thing to mention is, and I mentioned it in relation to infections, but as a standard, we would, in patients that were developing new itch or worsening itch, we would re-image as well, just to be sure that there wasn't any structural stricture in the bile duct that would warrant intervention. We've discussed already by undertaking ERCP, because there may in some instances be something that can be done mechanically to improve the flow of the bile out of the liver, which might be also effective in dealing with the itch. And then the final thing is just I agree, in rare instances, transplantation, there would be an indication for transplantation even in patients that don't have advanced liver disease or decompensated liver disease, but that in reality in PSC that is really rather uncommon, that things need to go to the extent that a transplant is necessary. Thanks.
I might just add one other thing, and that is that in females, look to, well, all males, but look to make sure you're not on any medications that can promote itch as well. So progesterone containing medications can promote itch as well. So
okay, I think that was really answered very clearly, and we've gotten to all the different possibilities to help these patients, and we can only hope for more in the near future with all the different research that's being done today, that I know there are several drugs on their way. And I think everybody has to be very hopeful that it's going to happen soon, and we'll have something to help us again. Now, next question that we have for you is really something else that has to do with the different things that really affect the quality of life of patients today. What can help with chronic fatigue, weakness, brain fog, all of those things? Because those are things that also people really do suffer from.
If I may start with this, I think this is a very difficult question, and I'm curious to hear the opinion of the colleagues in the UK and Australia. Of course, the first thing is to evaluate the status of the bile duct and whether there's no infection, and if you excluded all these possibilities and there's still chronic fatigue, it's clear that we need more research on the pathophysiology to know what is the reason behind that. We know this is also relevant in another rare disease, which is PBC, where it's more described and more clearly present. Let's say not more clearly present, but well known and more researched. And at least there's some data that parts of the autonomic nervous system plays a role in this chronic fatigue. And we don't have a lot of things to as a physician to support in that. What we try to do is offer physiotherapy as some kind of recompensation and rehabilitation, and try to have patients reintegrated in physical activity. But of course, after exclusion of infections and other complications. But that's really, I think, let's say, a point of research that we have to pay more attention to. And at least in clinical trials, we see that the quality of life, and especially the chronic fatigue, is taking into account, and is taking also into account as an endpoint or a secondary endpoint. So I think we will see some effects of the novel treatments, hopefully, on that aspect in the future.
I might add, I mean, most of my PSC patients I have also have inflammatory bowel disease, as with most people, but given I run the inflammatory bowel disease service. And I am very careful and being quite thorough in making sure there's not another contributing factor to the fatigue besides the PSC. So I'll check their thyroid function, their iron studies, their vitamin D levels, and I'll make sure that if we can correct something else, that may just have a little bit of an impact on the fatigue. And I don't think we fully understand what causes the fatigue. My personal feeling is that it is the chronic inflammation that's in the bile ducts. And so when anyone has inflammation in their body, they have a higher metabolic turnover. So that's using up energy that would normally just be used for the running of your body and the cells and moving around and thinking and your heart pumping. And there's this extra energy burden from the inflammation in the bile ducts. And it's the same with inflammatory bowel disease. So if someone's inflammatory bowel disease is active, that will also make them feel more fatigued. So I guess dealing with any inflammation that's there, whether it be in the bowel, I think that I agree completely with Professor Van Walligem that if we have a therapy that works for PSC and reduces the inflammation, I hope that will improve fatigue. And I was part of a phase 2 trial of an interventional therapy in PSC. And my patient, actually, I found out later, got the highest dose of the drug. And he told me he found a spring in his step he never realized he'd lost. And this particular drug is now almost completing phase 3 studies, and we're hopeful it will be beneficial. And I just have hope that if we find a beneficial therapy that can reduce inflammation, that may help fatigue too. And the last thing I'll say about fatigue with my patients is I look at what their day-to-day life is like and their work is like. And I see how we as clinicians can support patients with their work. Shift work is terrible for people with fatigue. So if we can help with writing a letter about their condition of their employer, work out what part of the day they're less fatigued and help them with having work that fits in those hours, and also telling my patients to be kind on themselves as well, and not try and overdo things as well with work and various things.
I think the only thing that I would add, and I agree with the comments that have been made, it's a very difficult symptom. It's a very common symptom. And we know more about fatigue in PBC than we do know or understand in patients with PSC. The only thing that I would add, and I think Thomas has alluded to already, is that the pruritus that patients get is often nocturnal, occurring at night. And so if patients have disturbed night sleep because of troublesome itch, then it kind of a knock-on effect in terms of daytime sleepiness. So it's really important to, as Kate described, exclude all the treatable causes of this, like anemia, like thyroid dysfunction, etc., but also double down on the management of other symptoms that may have an impact on people's sleep patterns and their therefore their ability to function during the day. The only other thing I might add is that unlike the two other symptoms that we've described, fatigue is not an indication for liver transplantation. In patients with advanced chronic liver disease and cirrhosis, where the liver is showing signs that it's failing to work, normally patients often feel fatigued. But the transplant is being undertaken to treat the cirrhosis and the failing liver in those circumstances. In patients whose primary symptom is just fatigue and their liver disease is not advanced, then transplant has been shown to have disappointing outcomes. There's not great data around this, but it dates back to the kind of 90s, mainly I think in BBC, that when people undergo a transplant, the fatigue doesn't improve. So it is a very challenging symptom.
Thank you so much. And thank you for those very compassionate answers. We're going to move on to another very troubling symptom, and that is right upper quadrant pain. Patients are often told by their physicians that their right upper quadrant pains are not caused by their liver disease. And this obviously can have a very strong impact on quality of life. Is there any research on this subject? Is there a way to minimize the pain? Or do patients simply need to learn how to cope with it? Dr. Thorman?
Yeah, shall I make a start? So I think, first of all, I very much believe it is a symptom that people with PSC get. I think the PSC support did a survey in the mid-2010s, 2014, something like that. And they recorded that, I think, over the month or so before participating in the questionnaire, about over 50% of patients had experienced right upper quadrant pain. I would say there's quite a range in severity. There's, at least in my experience, and some patients describe it as an awareness or a nagging sensation in the right side of the abdomen. But there are occasional patients that have really severe, profound symptoms that are present all the time. And you see some very odd things, like patients who have very enlarged livers with PSC that are very firm. And you could understand why those patients are experiencing pain and discomfort as a consequence of the enlarged liver, maybe with a stretched liver capsule, etc. It's part of the features of episodes of cholangitis. So it'd be important to consider whether there's evidence of infection. And even if there's not, it's worthwhile giving a trial of antibiotics just to see if the symptom improves. Because, as I mentioned already, cholangitis can be below the level of detection clinically. So the blood test might not look particularly worse than usual. Imaging might not show anything, but it's still worthwhile giving antibiotics to see whether the symptom improves. Thereafter, again, it's reasonable to undertake imaging and be sure there's no significant stricture that's causing a very stretched and distended biliary system. It would be unusual for that to be the case, but it shouldn't be excluded as a potential cause. And I think if all of that's been done and imaging again rules out any evidence of any growths or tumors, say, in the liver, would be a key thing to do, then unfortunately it is a matter of just dealing with the symptom or managing the symptom, the pain, with medication to deal with that pain, because at that point there would be no clear intervention that could be undertaken. I haven't mentioned the gallbladder, but gallbladder stones, chronic inflammation of the gallbladder could be a potential cause. Some patients might end up having a cholecystectomy to see if that would help with the symptom. It sometimes does not. So I think it is a difficult symptom. It's a real symptom. There are cases where it can be treated and made better. There are, not, in my experience, again, some cases, not commonly, where it becomes a chronic, intractable problem that is difficult to treat. And again, it might be a symptom that ultimately would point you towards considering liver transplant, not for that symptom alone, but in the context of a liver that was showing signs of significant damage and cirrhosis, and maybe other features of the disease. But it would be a factor in the quality of life of that patient that might push you towards thinking about transplant earlier.
Yes,
so much.
Mary, I guess to answer the other parts of your question, not very satisfying answer, but I'm not aware of any specific research just looking at the right upper quadrant pain. There is research which Professor Thorburn been involved with in terms of making a quality of life score that can be used in trials and when we try various treatments, which incorporates the right upper quadrant pain, and therefore using these types of symptoms that impact quality of life as an endpoint for trials. So I think more and more for all sorts of diseases around the world, and the FDA, the Food and Drugs Administration in America, which is normally the first ones to approve drugs, there's a very big focus on patient-reported outcomes, such as abdominal pain, pruritus, etc., rather than just on lab measures like the ALP going down, or if someone needs a liver transplant. And so the FDA and all the other medicines agencies around the world are very interested in making sure that drugs actually improve patients' quality of life and not just prevent disease progression. So I think that even though I'm not aware, and I don't know if either of the other professors there are aware, I'm not aware of anything specifically just on the right upper quadrant pain, but I think with further trials, they are focusing on quality of life. And so we may learn some things about things that can help with the right upper quadrant pain.
Thank you. And I guess I would say to the patients that are listening, I do know that several of the patient groups are working on developing tools. And so and these tools are primarily developed through survey data. So please do participate when there are calls for surveys to understand your symptoms. The more data we have, the better we can advocate for the development of tools that can be used in clinical trials. So,
and can I add one more thing? Sorry, Mary, just the survey that Professor Thorburn mentioned from PSC Support, I had a feeling that it was abdominal pain rather than right upper quadrant pain that came out at about 50 or above 50%. It was the number one symptom experienced by people with PSC, but I had a feeling it was abdominal pain. And whilst is that right? Does anyone know?
I don't know.
Oh, Doug,
Dr. Thorburn, you're on mute.
I would need to look back. It's a while ago. It may have been abdominal pain. I can't recall.
I mean, I definitely think people with PSC do experience right upper quadrant pain, but I have a lot of people with PSC just in general experience abdominal pain rather than specifically right upper quadrant. And so part of me does wonder how much of that is also from the inflammatory bowel disease as well. And so I think getting on top of that and having really good care of the IBDs, having a dedicated IBD specialist, dedicated PSC specialist. If you're lucky, you might have someone who specializes in both. But I think making sure that the IBD is treated to target may also be helpful.
Thank you. So I'd like to turn to, the big question, which is what's causing all of this? Obviously, there's research going on all the time because we need to understand that. And I'm wondering if each of you can comment on what are you most particularly following, involved in, interested in, or is there anything particularly regional research going on that you are interested in around, the root cause of PSC and us understanding how this is starting? Why is this happening to patients? Dr. Van Wollingen, why don't you start?
Again, a difficult question. So what we are mostly involved in as clinical unit is in the European Reference Network, where we try to participate as much as possible by uploading patient trajectories and follow-up data with the goal of having large databases for let's say machine learning, artificial intelligence, and see what could be predictive of outcomes in patients with PSC. Of course, this will not deliver the answer to the root cause, because of course you want to know what happens before the diagnosis, before a patient presents with a specific symptom. And in my view, difficulties there is that doctors often, if they have a problem with a certain disease, they go back into animal models, mice or rats. And in my view, there's really a lack of a good animal model for PSC only. And this is one of the problems there. I am aware that there are investments in relationship between IBD and PSC. I think it clearly now more data will arrive on the gut-liver axis and the relation between the microbiome in the gut and how this translates to the liver. We last year more and more see that the liver is really a full part of the mucosal immunity that is there in the gut, and this is what I believe will learn us a lot. But we're really on the start of getting to know what the relationship between the gut microbiota, the gut immune responses, and then the development of PSC. And I do believe that with the investment of novel techniques like spatial transcriptome or techniques where we look at liver biopsies that have been collected in the past, for example, and with new techniques of advanced, let's say, looking at gene expression levels, so how the genes changes in the liver of these patients, might learn us a lot. But it's clearly a difficult disease to tackle, in my opinion. And I'm curious to know what the colleagues would think about it. But that's our unit is mostly now focusing on the clinical trajectory of patients by collaborating in the European reference network.
I agree with everything that you said there, and I guess I look more at the smaller side of research of collecting samples and then performing experiments to try and learn more about the cause is the area of research that I'm most interested in. And so we know, I think it's a mix of genes and environment. So we know there are genes that are associated with developing PSC, and almost all of them are to do with the immune system and the way our immune system interacts with the environment. And our microbiome is part of the environment, the way our immune system interacts with the bacteria that are in our gut. And so I'm interested in studies where we take samples from people with PSC and from controls, particularly samples from the liver or cells that are around the liver, like in the portal vein, and look at how the immune cells are behaving and how are they reacting. And that can tell us something about where we can target the immune system, because we do think it's an immune-mediated disease. Other immune-mediated diseases like inflammatory bowel disease, we've not quite cracked fully, but we're a lot further ahead where we can target certain immune pathways and get people in remission and change the trajectory of the disease. So there's increasing studies coming out of people looking at the immune cells directly from the liver. And in the past, it's been mainly from what we call explants. So when someone has a liver transplant for PSC and their liver comes out of their body and it's not used anymore, that we can do research from those cells. And some of my research has been actually taking liver cells from people living with PSC at earlier stages as well, in a safe way, using fine needle aspiration, and then looking at the way the immune cells behave. And then just more recently, I'm also saying to look at the gut microbiome with collaborators here in Adelaide. And if we augment the microbiome, can we then augment the way the immune system's behaving, and can that have a beneficial effect on the liver? So that's what I'm most interested in. And I think that it's going to be it's a combination of all these things, having the genes that predispose you to it and prime your immune system to behave in a certain way, together with some sort of environmental exposure, which might be the microbiome or might be something in the atmosphere, that then leads to this inflammation.
I agree with everything I've heard said, and it's really encouraging that, I mean, we don't have the answers to the underlying mechanisms, and there's a number of groups working in different areas, from genetics to microbiome, and I think we've got clues from the genetic work where the alterations are that are associated with PSC, but as yet that hasn't played out into any treatments that might alter the natural history of the disease. But it's a key issue to understand the fundamental cause of the disease, because it's only then that we can offer treatments that could arrest the disease, stop it, maybe stop it from developing, etc. Otherwise, we're just looking at treatments that might alter the course of the disease rather than interfere with the fundamental processes of the disease. The area that we have been most involved in are developing tools to measure the symptoms of patients. So I get Kate's spoken about this, but once a symptom is measurable, then you can see if treatments are having an impact on it. So and you can quantify the symptom, and it becomes an issue that you can point science at in terms of trying to make it better. Because if it's just a subjective symptom that people are describing, I feel tired, or I have a pain, for example, it then becomes difficult to say, in what way have you made that better? So that's one area. The other area is the non-invasive assessment of liver disease, and the reason that's relevant is that the natural history of PSC is quite long, and the complications arise over decades rather than over years or months, which is generally the length of time a clinical trial lasts for. And at the moment, the regulators are requiring liver biopsies as part of the regulatory approval process for new treatments for PSC. And so our interest has been in evaluating non-invasive methods to try and act as intermediary biomarkers and intermediate endpoints in clinical trials that might allow us to move away from biopsies, and that includes, sorry about that, that includes physical tests like ultrasound, variation on ultrasound, and quantified ultrasound and FibroScans, but also using fibrosis blood tests and evaluating them in the course of the disease as well. And through doing that kind of work, it's possible to identify the fingerprint of fibrosis in patients with PSC, and provides another opportunity to think about drug treatments that might target the fibrotic processes in PSC. So it's a means of measuring the disease, but it also provides insights into the underlying pathological processes of the disease, and where the opportunity might be to target the disease and prevent its progression.
Thank you so much. I mean, it's encouraging to hear you all speak of this range of activity, from thoroughly collecting clinical data to, looking at the smallest level of the cellular, what's going on at the cellular level with these samples from the liver, to, better understanding the symptoms, to, developing new tools to measure development. It's very encouraging for those of us who are affected personally by PSC. I think we should turn to where this all leads to for us now, how patients can take some action to improve their situation. And that is, I'd like to wrap up with a question about clinical trials. And you're all in different regions. So I'm wondering, I know there's been some potentially promising results recently from a phase 2 trial, which is, we don't get too many promising results in the clinical trial landscape in PSC. So we're very happy to hear that. But how can, so what are you excited about with the clinical trials that are going on? And is there anything happening in your region that you can update us on? For example, we we haven't heard much about what's happening with the NOR-URSO trial. I believe it's coming close to completion. But anyway, if you could each just speak to what's going on in your region and any encouraging words for participants, patients who would like to get involved.
I'll maybe pick that up first. I mean, in the last 5 years plus, certainly in the lead up to COVID, the number of clinical trials in this area and the number of companies that were interested in developing treatments for PSC has increased dramatically. As I've said already, the treatments that are being evaluated may have been developed for other diseases or for other indications, but because of elements of our understanding of the disease, they've been applied to PSC because we still lack that fundamental understanding of what's the cause of PSC and the key steps in its development. So there's a number of phase 2 trials and phase 3 trials. The NOR-URSO study, I think the data on the 2-year outcome, so it's a phase 3 study with biopsies. There was a phase 2 study previously that showed encouraging results around biochemical endpoints, so alkaline phosphatase. And so they've gone to a phase 3 study that involves biopsies. So the outcome of the 2-year study should be available around about next summer, possibly. I don't know the precise timings, but there may be some results around the time of the European Liver Meeting, or if not, maybe the American Liver Meeting at the later half of 2024. Unfortunately, the Gilead study Primus of Cilofexor was terminated earlier this year. It was a phase 3 study because it again had histology, and unfortunately there was no evidence of improvement in liver appearances in those patients that were treated with the drug. So that was very disappointing news. But there continue to be positive noises, like the Pliant study that you've referred to. Is I think there's been a press release around that, and the scientific presentation will be at the American Liver Meeting at the beginning of November, and everybody will be waiting with intense interest to see the findings. And I'm sure there'll be plans thereafter about where to go with a positive phase 2 study. The other study that's coming is closing or just about to close is the Spring study from Chemomab, and they've fully recruited. It's been a bit slow to recruit to, and there's been some refinements in the protocol, and partly that was due to COVID, but it's now successfully recruited, and there's been a real acceleration of recruitment in the last year or so. And again, the results of that phase 2 study should be available roughly next spring, so maybe for the EASL meeting. And again, it's a very novel approach. It's not a bile acid therapy. It's not an antifibrotic therapy. It's an anti-inflammatory and antifibrotic therapy. And then the final study, just to mention, is the MIRROM study, which was set out to treat patients who presented with significant pruritus, and there's been refinements to the protocol. It's open in quite a number of centres now, but the protocol's being refined now to include patients with very mild itch as well as more severe itch. But it's still got a way to go until it's recruited sufficient patients to lead to any conclusions. But I guess it's just to highlight there's a lot of clinical trial activity. Really encourage patients. There's a dearth of treatments that we know are effective for this disease at present. So a lot of the care is around watchful waiting and early action if a change in symptoms occurs. So I would encourage, if patients are eligible, to at least consider participating in clinical trials, which could potentially help accelerate the availability of treatments to patients that will improve the quality of life or the life expectancy that may be associated with this disease, if we can find those treatments that are effective.
Anybody else have anything else to add on to?
I think this is a very complete answer. Yeah, we don't have anything to add. Some studies are enrolling in Belgium, others are not. I do believe or hope that for the pruritus we'll find another treatment soon, or an additional treatment, and I have some good hopes for that. But we'll see. We're expecting the results to be shown in the coming international liver meetings.
Thank you.
And that was a lovely overview, Doug, of all the studies that are going on. In Australia, we haven't really had trials in PSC until just recently. The trials have started coming to Australia, which is wonderful. So we were involved with the Premise study, the Carlifexor drug that was the negative study released recently that was terminated early. And ongoing, we're involved with the Pliant Integris PSC that just had the positive press release. So and I think that Mirum are thinking about bringing the bile acid inhibitor study that Doug mentioned as well out. So for people in Australia, it is promising. And then in different states and some nationally, there are some not national pharmaceutical driven necessarily, but some microbiome type studies in terms of manipulating the microbiome or giving vancomycin as well that are available in Australia.
Wonderful. Once again, I'd like to say thank you to all of you for giving yourself your time today. I know how busy everybody is in each of their own days, and in the middle of the night, early in the morning, whatever it is. And really thank you from the bottom of my heart, and to all the patients that have PSC. I really want to say to you all, please speak to your doctors about the fact that you have symptoms. Tell them, ask them what is available for you in your area where you can get involved in a research. These things are going to help us move along. In the end, we're going to find a cure. We're going to find a way to stop the progression of this disease, and to, first of all, to help the quality of life of each of us. Please know that we're here for you, and working together. Our motto is that we're stronger as long as we work together. So please, everybody, be here for us, and we're here for you. Okay. Have a good day, everybody, and please stay tuned to other things that we're going to do together. Bye-bye.